The assessment thingy, well, if you use that.
It doesn't matter to me. I can price it with a computer paper.
Yes, sounds cool.
Okay. Jesus God. Okay. Whoever wants to be the other victim to do assessments, Sarah's up here. So
So we have it.
she's here in spirit. Well,
Yeah.
no, you all get to come sit in front of the computer. Get in the habit of, yeah, get in the habit of going in and writing it, because it's exactly the way it's going to be in your skills. So, or I'm sure Sarah will walk through it with you as you write it down, so you guys can remember it. Okay. All right. You guys, you can be Sarah's victim, just like somebody, anybody. Don't make me start picking people. There's a metal one in the back of the ambulance.
That answers that question.
Oh, you can't even see me. Not that you need to. All right, my blank paper.
Okay,
I'm gonna take a minute to write the things down that I want to write.
go for it.
Yeah.
That's terrible.
Can't.
Yeah, fucking right. You know how quickly we lose our job when we're calling off for a final? Oh, yeah. Oh, yeah.
Do they not let you do like some kind of part-time?
No, the last person that asked to do part-time got fired.
Yeah.
Yeah, it's all or nothing.
Okay. I think I'm ready.
Okay, am I doing medical or trauma? Did they specify?
I think whatever we're missing,
Did you do your medical? We did it with Jamie?
I don't,
All right, who wants to do IVs?
I'll do it.
let me look at my phone to see if I'm missing one or
Okay.
the other.
Can I come in?
Oh, so it says I have 1 of 2 medical and 2 of 2 here. Let me see, hold on. I have 0 of 1 medical instructor and 0 of 1 trauma. But we did do one with Jamie. I believe mine was a medical. I'll have to ask her about that. We did one with her online.
Okay,
But I have 2 of 2 peer for trauma and 1 of 2 peer for medical.
So you're testing your assessments, right?
Yeah.
So I just talked to Jamie. So the ones that we did in class on the Zoom the one night, those were just practice. So we do our medical and our for our test out.
So we just need 1 of each,
Yes.
right? Okay, so we need 1 of each.
okay. Do you have a preference as to which one you do?
We can do medical.
Medical? Okay. I don't have my iPad, so I'm just gonna write down your name, and then if you passed or failed, and then I'll sign off on it for Jamie. So remind me your first name again. I haven't worked with your class so long, I'm sorry.
Angie.
Angie, I thought so. You're doing medical. All right, you ready?
Yep.
Okay. You are responding emergent for a female patient, respiratory distress. Time is 17:13 or 19:13, excuse me.
Stress. Okay. So scene safe,
Yes.
CSI. This is an illness, not an injury.
Yep.
I have 1 patient.
Yep.
I would consider C-spine if it were necessary, but I don't feel that is the case.
Okay.
And I will consider requesting additional help once I get more information.
Okay.
What is my general impression?
You have a 54-year-old female patient who is sitting tripod on an outdoor deck chair. There are cigarettes near her. She is in what appears to be some form of distress.
What is her LOC? Is she talking to me when I approach her and I ask her questions?
She is alert and oriented ×4. She's just anxious.
Her chief complaint, according to her, is
She says, I just can't breathe.
okay. So at this point, what is like her breathing like? Is it, I mean, I'm not gonna do vitals yet, but what is her airway? What's happening with her airway and breathing?
So her airway is patent. Her respiratory rate is 26 and labored, and she has audible wheezing in all lung fields.
How is her skin color, temp condition?
She's flushed, warm, and dry.
All right. So at this point, I'm gonna at least get her into the squad.
Okay.
So does she, well, is she on oxygen at home?
No.
Okay. So, okay, she's at 26 and labored. So I would go ahead and put it, just for now, put a non-rebreather on her at 10 to 15 liters per minute.
Okay.
What's her pulse ox?
Her pulse ox is 93% room air.
3%. Okay. What is, when did this start?
Do you want onset or time?
Onset,
It was sudden onset.
sudden, okay. Anything that makes it better or worse?
She says nothing.
Okay. Does she have any allergies?
She is allergic to penicillin and bees.
Was she outside when this happened? Did she get stung by a bee?
She says that she was sitting outside when she felt a sharp pain in her leg. Breathing troubles began shortly after. She states she was outside trying to find a bee's nest that her son saw the day before.
Okay. Okay. Does she take any medications?
She has a PRN albuterol inhaler. She takes Flovent, Diltiazem, Eliquis, and she has an expired EpiPen.
What is her history?
History of COPD, AFib, and bee allergies.
Okay. When did she eat or drink last?
About 45 minutes ago.
Okay, so we're gonna start going towards the hospital. What has the non-rebreather helped at all?
She says a little bit. She's still wheezing.
Is her pulse ox still the same?
Pulse ox is now up to 96% on the O2.
Okay, what is her heart rate?
Heart rate is 112.
Blood pressure?
Blood pressure is 90/50.
Okay, so I would give her, so I think this, my impression is that this is an allergic reaction to the bee.
Okay.
So since her EpiPen is expired, I would give her, use the EpiPen on the truck and give
Okay.
that to her. IM. Does that help?
Yes.
Okay. Is she still wheezing?
No, not as bad.
Okay. Has her, I would reassess her vitals again after the epi. And she's no longer wheezing. Has her respiratory rate and SpO2 improved?
Her respiratory rate is now down to 20. Her pulse ox is now 99%.
Is she still labored at all?
Not as bad as she was before.
Okay, so I would just continue transporting to the hospital. I would consider starting a line just in case we would need it, or the hospital might need her to have one.
Okay.
If her breathing were to get worse, I would consider doing a breathing treatment. Other than that, I think I'm done.
Okay. You don't have anything else you want to do?
I mean, I don't think so.
Okay. So when you're doing a medical assessment, the one thing that we need to remember is that you have to do a secondary assessment. So, and remember, in trauma, you're looking for signs, things that you can see and treat. So you like get them trauma naked, you do the whole assessment. Medical is the symptoms. So the stuff you have to ask for. Are you having any chest pain? Do you have a headache, and are you dizzy? Do you have any like musculoskeletal pain? Any changes in bladder or bowel habits, any reproductive history, stuff like that.
So
You
I
were
forgot my little person down here.
That's okay. You were on board with the treatment, and EpiPen or IM Epi is acceptable. I was looking at the UH scope of practice when I wrote this scenario earlier. Let me pull it back up real quick. This freaking protocol is a pain in the butt to navigate sometimes. So it is within your scope of practice to also consider Benadryl.
Okay.
So you were good. You were on board with the breathing treatment. Perfect. If indicated, also, but just keep in mind, like Epi and Benadryl go really well together in an allergic reaction situation, and then a fluid challenge, because she's starting to show signs of anaphylactic shock with the low blood pressure, the high heart rate. So you're going to want to do an IV and a fluid challenge. I guess my theory is, as an ALS provider, anytime you give a medication, the patient should have a line.
Right.
So, and you're also giving epinephrine. So it's another thing that you want to do in regards to like patient monitoring and assessment.
I mean, keep an eye on her like heart rate and blood pressure, because that would be affected.
Maybe put her on the monitor, get a 12 lead and send it just in case. Like again, you are giving epinephrine, and while you're not giving the cardiac concentration of epinephrine, it still has all of the same properties. So you're going to want to watch that heart rate, make sure it doesn't go up too high, and keep an eye on those vitals. But otherwise, you're on the right track. You got everything I was looking for. Good job.
Thank you. All right, I will send the next victim over.
Okay.
Already did it. Sarah, I'm borrowing your notebook.
Hi.
Hi, give me 1 second. I'm trying to print out actual physical skill sheets because I forgot my iPad at home. Oh shit, that's the right thing. Work. Watch this not print to the right. Oh, nope, it did. While I'm doing this, you can take a minute, write down whatever you want to write down for the skill, okay?
Cool beans, thank you. Remember before you do that.
So do you need a trauma or a medical?
Yeah, we need one of both.
Okay, so which do you want to start with?
We can do medical.
Okay, Destiny, right?
Yes.
You ready?
Yeah.
So your time is 19:27 and you are dispatched for a 67-year-old male, severe chest pain, difficulty breathing.
Okay. All right, BSI is run as my scene safe.
Scene is safe.
All right, so, illness or injury, which honestly they can go, illness or injury with the chest pain and shortness of breath, but because we said it's medical, I'm gonna assume it's an illness.
Okay.
Only one patient.
Yep.
Consider C-spine, but right now I don't think we need C-spine.
Okay.
And I'm gonna consider help because this is chest pain. I'm automatically just gonna have a medic come as soon as they can and just do what I can until they get there.
Okay.
What is my general impression of this patient?
You have a 67-year-old male pacing in his kitchen. He is diaphoretic and pale.
Okay, level of consciousness, I mean, is he alert and oriented?
He is alert and oriented ×4.
Okay, chief complaint, chest pain and shortness of breath.
Yep.
How's his airway? Is he talking to me and answering questions?
He is.
Okay, how's his breathing?
Respiratory rate's 26. He is breathing adequately, just a little faster than normal. Lungs are clear and equal.
You said, what's his color?
Skin color?
Yeah.
He's pale, cool, diaphoretic.
Okay, so at this point, I would just decide to get him in the truck and try to transport as soon as possible.
Okay.
First thing I'm gonna do is get him on the monitor. Do a 12 lead.
Okay.
And then, let's do vitals. What is his heart rate?
Heart rate is 55.
Oh boy, that's a low heart rate. What's his blood pressure?
Blood pressure is 156/92.
All right, oxygen.
He is 98%. Actually, wait, no, he's 92%, sorry.
82%. Okay.
92%.
And then his sugar.
Sugar is 110.
All right, so immediately because his oxygen's at 92%, I'm gonna put him on a cannula at 3 liters.
Okay.
And then what is it showing on the monitor?
It is showing sinus Brady with what appears to be elevation.
Okay, so because he's having chest pain, I'm going to give him 4 baby aspirin and 1 nitro tablet because his blood pressure is high enough that it will allow it.
Okay.
So wait a minute. Does he have any allergies?
He's
Before-
allergic to aspirin.
Okay, there we go. We're not going to give the aspirin. I backtracked. Well, I sped up, I should say. Allergic to aspirin, so we're not going to do the aspirin. What kind of medications is he on?
He takes metoprolol, omeprazole, and atorvastatin.
Okay, he has not taken any Viagra related medications, right?
He has not.
Okay. What is his history?
His history is hypertension, high cholesterol, and GERD.
Okay. Last oral intake.
He says he had lunch 3 hours ago.
All right. And then what was he doing when this chest pain started?
He was out in the backyard push mowing his lawn.
Okay, yeah. So not gonna do the aspirin, but I am gonna stick with the nitro.
Okay.
Because his vitals are allowing. So when the chest pain started, was it like sudden or gradual?
It was sudden.
Okay. Does anything make it better or worse?
Nothing.
All right. Can he rate it on a scale from 1 to 10?
He says it's about an 8.
Okay. And then does it radiate anywhere?
Down his left arm and into his back.
All right. And then how long has it been going on?
About 45 minutes total.
So I'm in the middle of something. Oh, I thought he said Destiny. I'm sorry. So yeah, I gave him the nitro.
He wants his next victim.
Sorry, I'm
You're good.
He's the one that ever says.
Do the nitro. Gonna at this point transport, if our medic isn't there, have them meet us somewhere, just in case. I'm going to reassess my vitals, and see if he's still doing okay with that nitro. If he needs more, give more. So how are his vitals now?
His blood pressure is now 138/86. Heart rate is about 57. Did we put him on oxygen?
Yes.
Right,
I've-
okay. He's
Yeah.
98% on O2. And what, did you want to know anything else?
No. And then he's handling the nitro. Does he still have chest pain?
He says it's not as bad as it was. It's now about a 3.
Okay, so I'm gonna withhold giving any more medication. Just continue to monitor. I'm gonna keep this at a code 2 transport to the ER. Call in my report en route and just keep an eye on him to make sure that nothing changes.
Okay.
I
Is there anything
think
else you want to do for him?
no.
Okay. So like I just told Angie, let me just put your end time. You guys need to be doing the secondary assessment. So that's our question stuff, right? That's when we're in a trauma assessment, we're looking for signs. We're getting them trauma naked and we're looking to see what we can visualize and what we can treat from there. In a medical situation, you have to ask those questions relating to body systems, right? So we know he has chest pain. We know he has difficulty breathing. Does he have a headache? Any dizziness? Any changes in bowel or bladder habits? Any urges to have a bowel movement? Any musculoskeletal pain? You ask if he takes Viagra, which is good. Are you a smoker? Are you a drinker? I think that pretty much covers it. But we need to make sure that we're asking those questions because that's worth 5 points. And while it's not technically a black and white critical fail, you can have preceptors that will ding you on the critical fail criteria of uses or orders a harmful intervention or actually both of them, I'd say exhibits unprofessional behavior because you have preceptors that are going to be assholes about stuff. I mean, we don't pick the assholes, but sometimes like they slip through the cracks. And if you don't ask a question relating to the body systems, right, and then you do something and it makes them worse, is that technically a harmful intervention? You're back, but you're muted.
There, okay. I was like, wait, is it fixed?
They didn't want to talk to you no more.
The Wi-Fi cut out and I was like, uh-oh.
Well, like the Wi-Fi cut out and you were sitting there like this, and I was like not lecturing, but I was talking, and I was like, it was like, okay, maybe she's listening to me, and then you didn't move, and I was like, lost her.
Yeah. You were like mid-sentence and then I was like, uh-oh.
But what I was getting at is you need to do that secondary assessment because we need to make sure we're not missing a symptom, right? Because in a trauma assessment, you can see everything that you're treating. I can't see that somebody's having chest pain. I can't see that somebody's dizzy until they fall. Don't walk your patients to the cot. I can't see like things that they are feeling because I mean, it's not a physical sign. So make sure that you're getting those so you don't get dinged on the points or on somebody saying something like, you know, harmful intervention because you didn't ask the other questions. Otherwise you're good. You're on the right track. I can tell that like you have your own way of doing things like in the real world because you're kind of all over the place. And while you're hitting the points, I just don't want you to go into your skills session and the preceptor miss something. So for the purposes of this, and I mean, I've been there, done that, medic school, you have to, like, I had to reteach myself how to go down the line, but try to keep it linear just so you don't miss those points. Because if the preceptor doesn't hear it, it didn't happen. But otherwise good. I did a physical sheet, so I will scan it and send it to Jamie later to get you a sign off for medical.
Sounds good. Thanks.
Yep.
Sarah, do you want to go next? No?
Not yet.
Well, that sucks because you're next. We're sending Sarah over.
Look over it.
It's the same system we does. It's basic school. The only difference is ALS intervention. Oh, I definitely, well, never mind. I'm not gonna say that. It'll be fine.
I'm here.
Okay. Take a
You've been
minute.
popping up on my Facebook lately.
Have I?
A friend request, yeah.
My Facebook, my feed is, what I share is just shit posted Facebook EMS memes. That's all.
You know what? I would totally steal them though.
Take a minute, write down anything you need to write down. Let me know when you're ready.
Okay.
After what? Good Lord.
Okay, I think I got it.
All right, are we doing medical?
Sure.
You are dispatched for an 84-year-old female, multiple falls today, requesting evaluation for generalized weakness.
Okay, so BSI seems safe.
Yep.
So,
Before you get confused, she's requesting evaluation for the weakness, not for the falls.
okay. Because I was gonna say, wait a minute, this sounds more like trauma than medical. Okay, so this is gonna be an illness.
Mhm.
And I have one patient.
Okay.
Because she's asking for evaluation for the weakness, I'm not going to need C-spine. And I do not believe I'm going to need help at this time, but if I do, I can call for that here in a little bit.
Okay.
General impression, 84-year-old female, several falls, and extremely weak.
Yep, currently sitting upright in a recliner, no apparent distress.
Okay. Did she lose consciousness when she fell?
Nope.
So the chief complaint is going to be weakness that caused her falls.
Yep.
You said she's sitting up, no distress.
Yep.
She's talking to me, so her airway is clear.
Yep.
Talking in full sentences.
Yes, ma'am.
So her breathing is okay, and I'm going to assess her circulation to make sure everything is good there. At this point, I would consider getting her in the truck so that I can get my vitals.
Okay.
As soon as I got my vitals, then I would initiate transport.
Okay.
So, signs and symptoms is her weakness.
Mhm.
Any other complaints?
She complains of ongoing left foot pain that was not caused by the falls.
So at this point, I want to do my head to toe assessment so
Okay.
that if I see anything, I can address it. I would check her head.
She says that she has not had any loss of consciousness in the falls. She has no current headaches, no dizziness, no signs of trauma.
Okay. Anything with her upper extremities?
No.
No, okay. You said this was medical, so.
Yep.
I would do the head to toe assessment just to see if I see anything. Since I already know this is medical and not a trauma, I'm going to assume that everything's clear.
Yeah,
Does
she
have
says that the foot pain, the aching in her foot started a couple days before the weakness started. So that's something that's been like ongoing. That's not a new issue.
Okay. I will mention that when I call in a report.
Okay.
Any allergies?
She is allergic to penicillin and lisinopril.
Okay. Is she on any medications?
Yeah, she takes metoprolol, insulin, gabapentin, and daily aspirin.
Did you say insulin?
Yes.
Any past medical history?
Yeah, she is a type 2 diabetic. She has hypertension and neuropathy.
When's the last time she had anything to eat or drink?
She had a snack about 35 minutes ago.
And the events leading up to this, is that the falls?
Yeah, she's just been getting progressively weaker. She's had a couple of falls. Her family is concerned and they want her evaluated.
How long has this been going on?
She says it's been going on for about 3 to 4 days.
3 to 4 days.
Mhm.
When was the last fall?
About 2 hours ago.
Okay.
It took her family that long to convince her to let them call an ambulance.
Has she been eating or drinking normally?
She's been trying to keep up on it. With the weakness, she doesn't have much of an appetite, but she's been trying to snack on some stuff.
Um, And for the
She knows this.
pain in her foot,
She hates her.
does it like go anywhere or anything?
Nope.
And for the pain on a scale of 1 to 10,
She says it's like a 4. It's nothing super bad.
throbbing, aching, stabbing,
She says it is a dull ache.
doesn't radiate anywhere.
Nope.
I'm forgetting what S&T stands for in the OPR QST.
That's okay. Move on. You can come back to it.
It's not going to come back to me at the moment, so give me a minute. Okay, so at this point, I'm going to get baseline vitals.
Okay.
What's her
Heart rate is 102 and regular.
blood pressure?
Blood pressure is 100/70.
Pulse ox?
Pulse ox is 96% room air.
Respiration
16.
and regular?
Yep.
And a blood sugar.
Blood sugar is 250.
Okay, so because her pressure is a little low and because her sugar is high, I would start an IV.
Okay.
I would tell my partner to go ahead and start driving.
Okay.
I don't think I need any kind of assistance at this point, so I'm just gonna go ahead and transport myself.
Okay.
So start a line and I would start some fluids.
Okay. What would you give her?
I would start off with normal saline.
Okay.
I probably would do 250 at
Okay.
first, just to see if that brings the pressure up a little bit. And I would reassess everything.
Okay.
I would reassess the heart rate, blood pressure, and make sure that everything is still going okay. I'd assess her breathing, circulation, all of that.
Okay.
What are my vitals now?
Let's see. Blood pressure is 102/68. Pulse is about 100. Pulse ox is still 96%. Respiratory are still 16.
And sugar?
It's still
I know,
250.
I know it doesn't take effect that quickly, but sometimes,
It's good to reevaluate.
but just reassessing. I would continue to give fluids and I would call in a report. You know what? Because her pressure is kind of low, I would probably grab a floor lead just to make sure that everything looked good there.
Okay.
What did I find on my floor lead?
4 leads, just sinus tack.
Yes, okay. So everything seems to be going okay. Is she tolerating the fluids well?
Mhm.
Okay,
Yep.
at that point, I would call report and continue my transport.
Okay. Anything else you want to do for her?
I don't think so.
Good. You were exactly on the track that I wrote that scenario to be. She's in the beginning stages of DKA. The foot pain, this is based on a real call. The foot pain is just thrown in there as she has neuropathy. She has ongoing foot pain. So also be inclined to think possibly sepsis if she has a wound. In patients like this, it's not a bad idea to also ask for a temp, especially in like generalized weakness patients with low blood pressures, textbook tachycardic heart rates, and elevated sugars, because that when you have an infection, you know your blood sugar is going to spike, your other vitals are going to get all jacked up. She's probably going to be febrile. The 4 lead was a great call. The fluids were a great call. She probably would have tolerated like a 500 bag just running at KVO, but yeah. Make sure in your primary, you said you were going to assess circulation, but you didn't actually verbalize it. So make sure in that primary assessment, I know it's a medical, but do I see any major bleeds? What's her skin color, temp condition, and pulse?
Okay.
Just because you said it and you were like, I'm going to assess circulation and then I'm going to get her to the ambulance and get some vitals. And I was like, you just didn't specify, but you did good. Your OPQRST, the only thing you forgot was onset. It was just a gradual onset, which we kind of would have assumed based on the 3 days.
The onset is when I asked, and you gave me the 3 to 4 days.
That's time. Remember, onset and time are different. Onset is sudden versus gradual. Time is how long it's been going on.
Okay, so I was confused on that. So
That's okay.
T in the OPQRST, isn't it? What's
Yep.
the S? My
Severity.
brain. Severity. Okay. Well, then I asked that on the 4 out of 10.
Did you ask that?
Yes, you told me 4 out of 10 on the pain.
Okay, yeah, you did. No, I have you marked down for that. You forgot provocation. That's the other thing you forgot. The onset, provocation, quality, radiation, severity, time. There was nothing that was going to make it better or worse. Maybe a little bit of rest would have made it better, but nothing that was going to change the treatment plan.
Okay.
When you did the secondary assessment, you did good on that. I know I kind of threw you for a loop there with the throwing in the foot pain thing, and you did a great job with this scenario because like when I first gave it to you, I was like, okay, yeah, like I know the track that I wrote it, like I know the track that it's going down. And then I was like, oh shit, but you did really good with it. Just when you do a secondary and a medical, remember we're asking for symptoms because we can't see the symptoms. Are you having any chest pain? Are you having any trouble breathing, any dizziness, lightheadedness, nausea, vomiting, diarrhea, any urinary habit? I think you asked that. You did. I gave you credit for GIGU because you asked about her appetite. And I gave you neuro because of the no loss of consciousness. You asked about the head. So you did get 2 points there out of 5, which is good. Good with your vitals. Make sure you guys are stating a field impression. I think this is a hyperglycemic related emergency, generalized weakness. It's only 1 point. It's not a critical fail or anything. But if you're kind of like skating by on a point-based thing, I don't want you to miss a point and it knock you down to where you're just like right under it. But otherwise, great, good reassessment, good treatment. You did great with the scenario because this is kind of a shitty scenario, but I'm very proud of you because this is actually written to be a BLS scenario. And I made it, like I kind of tweaked it to make it ALS and you did really good with it. So good job. Think you're good on point.
I was going to screw it up.
Nothing to be scared of. You got it. You're good.
All right. Who else do you
Take
still
a breather.
Who else do you still need?
I've only had Angie, you, and Destiny. So whoever else is available.
Okay. You're next.
Yeah.
This is the most uncomfortable fucking chair I've ever sat in. So
You could be at Springfield sitting in this nice comfy chair.
I'm going up there Monday.
I heard that you got hired last night. Welcome to the shit show.
Well, I gotta go. I can't get my physical until Wednesday because they don't have a chest x-ray up there. Apparently there's a lot of shit that you gotta do for Springfield.
Oh, that's neat.
Yeah, blood work, everything. So if I'm gonna die, I'd like to find out now, I guess.
Fair enough. Take a minute, write down what you need to write down. Let me know when you're ready.
I got fed.
I've been doing that a lot lately. To find out how to count.
All right,
You want a medical or a trauma?
now we'll do medical since I'm already here.
Okay.
Study trauma again. I feel easier, but might as well get medical out of the way.
Okay, let me write your name down and stuff real quick.
I do like that you guys' new station up there.
Yeah, it's really nice up here. The station was built for staffing. And obviously we just now started, so now that it's actually being used for what it was built for, it's really
So
nice.
that's the main staffing building then?
Yeah, this is the only station we staff out of. The other two are like our callback stations or like our actual like fire stations because all of the EMS equipment's here.
That's what your cousin was talking about, getting me at his station since it's closer to my house.
Yeah, that'll be, so like if you're off duty, that'll be where you would respond if you're coming for a callback, like for a fire call, you would go there. Whereas if you're staffing, you come here. Let's see.
$20 to give me something easy.
Trying to find something. They're not all that hard. Have you been in the room for any of the other scenarios? Like, have you heard the girls go through theirs?
Like I heard them, I didn't hear what the call was. Well, the last
Okay.
one, obviously, because I was sitting right here up there.
Yeah.
It was like for DK, whatever it was. What else? John.
Here's one. You are dispatched at, Jesus Christ. If we're sitting on the mic, that can be done. You are dispatched at 2000 hours for a male at a local bar, alter mental status.
Yeah,
Hold on, the Wi-Fi cut out for a second there.
we know you're good.
Yep, you're good.
BSI scene safe.
Scene is safe.
There's gonna be an illness. It's
Okay.
not an injury. Number of patients, just one.
Yep.
If it was found, I'll consider C-spine if I need it, and I'll consider additional help.
Okay.
What's the impression of the patient?
You have an approximately 45-year-old male. He is sitting at a bar. He's leaning over the bar, kind of out of it.
All right, level of consciousness.
He is alert to painful stimuli.
Okay.
Yeah. Feels good. What else?
And the chief complaint would just be he's just not acting right, or he's
Yeah,
just
alter
out.
mental status.
How's his airway? Is it clear? Is there anything I need to worry about?
Airway's patent. It's okay.
Boy, how's he breathing? Like his rep depth or quality of breathing?
His rate's about 14. It's regular, nothing really remarkable.
Doing good so far. Circulation, what's his skin condition, color, temp, any bleeding I need to worry about?
No bleeding. Skin is pale, cool, and clammy.
And so right now I'm just gonna hang out at the bar and see if I can get something going for him right now, and we'll decide on that later.
Okay.
All right. So my onset, when did, who brought this on? Just
The
drinking?
bartender who's standing there says that he showed up to the bar about an hour and a half ago. It's been gradually getting worse, like his altered mental status has been getting worse since he got there.
Okay. And they make it better or worse? Drinking makes it worse, I'd assume.
The bartender says that he's only had one beer since he's been there.
And nothing's helped it since then?
Nope.
I would, well, quality, if there's someone there that can talk to me, is like, is this as normal or?
There's a couple guys that are sitting with him. They say that they drink with him often. He's never been this bad before.
Okay, so is there any pain that would be radiating anywhere, or did he?
Nope.
What the fuck is that? I think there's a stop rocket right here. Sorry. Hi. So if they would have to rate it, 1 being normal, 10 being never seen it before, what would they do? Rate it?
They'd say it's about a 10. They're like, he's not even like this when he's drunk.
It's not even like that when he's drunk.
Nope.
About what time they said it started? About an hour ago?
It's been about an hour and a half, yeah.
All right. Is he on any medications? Is he allergic to anything?
Unknown on both.
Okay, past medical history?
The one buddy said, I don't know, I think he has problems with his sugar, but I'm not sure.
Okay, perfect. And I don't suppose anyone could tell him the last time he ate or drank anything other than at the bar?
They said he's had one beer at the bar and he ordered some nachos, but only ate one of them, like one chip.
All right. What was he doing before this happened?
The bartender says that the patient walked into the bar a little bit out of it, but didn't say like he was feeling sick or anything. He just sat down at the bar, ordered a beer, and then just proceeded to get worse.
All right, is he able to tell me if he's got like a headache, blurred vision, nausea, vomiting, anything like that?
He's responsive only to pain, so he kind of groans at that, but he's not really able to answer.
We'll do that part is out for now. What's his blood pressure?
Blood pressure is 110/64.
Heart rate?
Heart rate is 110 in regular.
What's his SpO2?
97% room air.
97. Since they did say he's a diabetic, what's his sugar?
40.
Wow. All right, and he didn't lose any consciousness, none. He's just hanging out, he's just out of it.
Yeah, he's responsive. Like if you squeeze his shoulder a little bit, he'll kind of groan and shrug you off.
But at this point, I am going to get him out to the ambulance. His
Okay.
blood sugar is low, and that's where I'm leaning with this. And is his airways pain? Is he able to like swallow if I give him anything?
No, he's not able to follow commands.
So he's gonna go out there. I'm gonna start an IV on him.
Okay.
Some D10, I think it's what it
D10? Okay.
is. Hold on, something popped up. I'm gonna go, and my field impression would be, you got a patient who is altered mental. He only had a couple beers, one here, and sugar's obviously low. So my treatment for that would be to give him the D10. Does he react to that?
Yeah, after a couple minutes, he starts to show some improvement in vital signs, mental status.
I'll recheck his BGL. Did it come up any?
Yeah, his BGL is now at 92.
92. All right, so I'm gonna let that run just a little bit, and starts getting too high, I'll cut it out. And then like I said, I'll go transport him at regular, and if something happens, then I will upgrade if needed, but I'll call the hospital and let them know that I'm in round with a 45-year-old male who was at the bar and he was just kind of acting funny. He only had one drink. found out that his blood sugar was 40. After some D10, it went up to 95. He seems to be doing all right with that. He's reacting perfectly until we're about 5 minutes out.
Okay. Anything else you want to do?
No,
All right, good job. Just make sure in your primary, you're assessing the pulse as part of your circulation.
yeah,
Did good with that. With that. You did, yeah. You pretty much hit everything. I don't really have much to add to it. Just make sure you're repeating, your primary and your secondary. Once he regained consciousness, he could have been like, do you have a headache? Are you dizzy? Anything like that. Like once he came back to you after the treatment, but other than that, you did good.
all righty. Does anybody else need to see Sarah? Tyler would be the one, right?
For the
Tyler's,
first round of assessments.
Yeah.
doing medical and trauma, or
she's doing whichever you need.
Well,
You're doing
yeah,
both of them,
really
right?
injuries, both.
Yeah, I can do both of them.
Yeah, so if you need a trauma, you can come to Sarah. So we're waiting on. Have fun. Thank you, Sarah.
Yeah, I'm gonna do my trauma.
That was the spookiest fucking noise I've ever heard.
Something over there, I don't know.
It's green.
Dollar General does.
There's a little gas station up here in my house. At least like a little rollover.
Sorry, she's getting a little breakdown over here.
Give me 1 second.
You're good, I'm writing stuff, so.
Okay. Is Poland going to pull a crew out of their butts for this call? Is the question. I think my brother, who is currently dispatching, just had a stroke on the radio. So that was neat.
The other day, it was Chris and Mandy both were like not able to use the English language.
My brother's dispatching right now for Austin Town, who dispatches the fire department that I'm at right now. And he just tried to copy Poland marking en route for a call, and I'm pretty sure he had a stroke. Also, I'm supposed to have another partner, so I have no idea if he's even here yet. Oh, well, not my problem. Actually, guys, hold on. All right, you ready?
Yeah.
All right, you are dispatched emergent for a male patient, unknown age, multiple stab wounds after a bar fight. Your time is 2013.
Okay. So BSI is around, is my scene safe?
Yes, your CSA PD is on scene and has the actor in custody.
Okay, so obviously this is an injury. I only have one patient, correct?
Mm-hmm.
All right, so I'm gonna consider C-spine. So is there any neck or back injuries? Obvious neck or back injuries?
Not that you can see now. It's all like front injuries.
Okay, well then I'm not gonna do C-spine. And then with multiple stab wounds, I'm gonna have a medic come en route just in case something happens. So what's my general impression?
Your general impression is an approximately 40-year-old male laying on the floor of a bar.
Okay. What is his level of consciousness?
He is non-responsive with a GCS of 3.
Non-responsive or unresponsive?
Sorry, unresponsive. GCS 3.
All right, so, I mean, he really can't give us a chief complaint, but I'm just gonna assume that he's been stabbed.
Mhm.
So, I'm going to open his airway and check his airway, make sure that there's nothing in his airway that would stop his breathing.
Airway is compromised due to decreased level of consciousness. It is clear otherwise.
Okay, you know what, at that point, I would just put in an OPA, and because he's a trauma, I would treat for shock, so immediately start just bagging because he's unresponsive.
Okay.
High flow O2, OPA, and just protect that airway, get that done. So since he was breathing on his own prior, what was his breathing before bagging?
Before bagging, he was breathing at like 10 times per minute.
Okay, yeah, so bagging is probably a good thing. So we're gonna breathe for him 10 to 12 times a minute. That's not right. Yeah, that is right. What's his color looking like?
Pale, cool, and clammy.
Is there any immediate life threats that I'm seeing? Any outstanding bleeding, just looking at him from afar?
He is bleeding from multiple wounds. The most pressing at this point are the wounds on the wound on his chest.
Okay. So I'm gonna decide that we need to transport him immediately. With him having that chest wound, is it like a sucking chest wound? Like what's the looking like of the chest wound?
It appears to be a sucking chest wound.
Okay, so I'm going to put on an occlusive dressing. Since we're already at the chest, I'm gonna listen to lung sounds. I know I'm totally going out of order, but just because we're already on the chest, that's when we're gonna listen to lung sounds.
Lung sounds are diminished on the right side, which is where he's been stabbed in the chest.
Okay, so with that occlusive dressing and the bagging, that should hopefully fix that.
Okay.
Right now. So now that we've had that handled, I'm gonna start at the head. Is there any stab wounds to the head, any bleeding in the head?
He has a couple superficial lacerations to the head, nothing major at this point.
All right, I'm gonna check his eyes. How are the pupils?
Pupils are sluggish but reactive.
Okay. Check. Is there any like deformities to the face at all?
It looks like his nose is a little bit crooked. He might have been punched, but no other deformities.
Okay, and then we already checked his mouth for the airway, so if anything was there, we would have seen it. Check the ears. Is there any like spinal fluid coming out, blood, anything like that?
Nope.
Okay. So moving down to the neck, do we see any JVD or tracheal deviation?
Trachea is midline. He does have some JVD.
Okay. So we're gonna move. We already did the chest. Let's move down to the abdomen. Are there any sort of wounds to the abdomen? Is he distended?
Let's see. He has some stab wounds, but there are no signs of evisceration. Bleeding can be controlled with direct pressure.
Okay, we're gonna keep that pressure. Try to just gauze and tape if we can, and just kind of move on from there. There's no like distension or anything, right? No guarding.
Nothing that, nope.
Okay. So move on to the pelvis. Is there anything going on there?
Pelvis is stable.
Okay. So I'm gonna move on to the extremities, pat down the arms. Is there anything to the arms?
He has stab wounds to both of his arms. Again, bleeding's controlled with direct pressure. They're kind of like right here, like he was trying to block it. Nothing significant, just a couple.
All right, and then what about the legs?
He has no wounds on his legs, no signs of trauma.
All right, so now I'm gonna flip him over and inspect the back.
Okay.
Does he have any stab wounds to the back or anything at all at the back that I'm
Nothing
seeing?
that Nope.
All right, so with him being unresponsive, I can't really get sample or OPQRST unless I ask bystanders. So if anybody knows about allergies, meds, pertinent history that I need to be aware of, I would obviously get that, but if no
Okay.
one's there, can't really do that. So I want to know when this happened. And I mean, can't really get OPQRST, but
Okay.
I want to know what happened, how long he's been on the floor unresponsive. And how long-
It's been about 15 minutes. They called 911 immediately. There was an altercation that broke out between two patrons of the bar. This guy said something about the other guy's girlfriend, and the other guy didn't like it, whipped out a knife and began attacking. Patient has been on the ground for about 10 of those 15 minutes.
Okay. I know I told you transport at after my thing, but I just want to make sure you know that we are already in the truck at this point.
Okay.
So I'm gonna get all of his vitals now, heart rate, blood pressure, SpO2, BGL, and I want to get a CAPNO too.
Okay. Heart rate is 110, rapid and weak.
Okay.
Blood pressure is 86/40.
Okay.
Respiratory rate is being assisted at 14 with a pulse ox of 95%.
Okay.
What else did you want to know?
Sugar and CAPNO.
Sugar is 186 and CAPNO is 48.
Okay. So I'm also gonna put him on the monitor, get a 12 lead going. See if we can have a medic meet us en route to the hospital. But I'm definitely gonna want to start an IV, get some fluids going because that blood pressure is low, but I do want to maintain, a 90 to 100 systolic, but not really overflood him with fluids.
Okay.
I would definitely reassess him every 5 minutes. But with him again being unresponsive, there's not really much that I can do to figure out if he's hurting anywhere or treat anything other than just get that blood pressure up, can keep the bleeding controlled and get to the hospital as soon as possible.
Okay.
So I would reassess my treatment, so I would make sure that his blood pressure was going up with the fluids. I would, again, make sure that the bleeding remained controlled, and reassess his level of consciousness, and just all his, oh my gosh, all around mental status. So GCS, AVPU.
Okay.
Yeah, you know what I'm saying here. Was there any sort of increase vital, or what am I trying to say here? Did his vitals get better, I should say?
Yeah, his blood pressure starts to come up a little bit. His heart rate still is sitting at the 110 area. Respiratory rate still assisted. Pulse ox stays the same and tidal stays the same.
All right, so at that point, throughout transport, I would call the hospital, give them like 10 to 15 minutes notice so that they can call a trauma team, and just keep watching him every 5 minutes, if possible, meet with a medic in case he starts to decline, but just keep an eye on him.
Anything else you want to do? Perfect. Good job. Make sure you are verbalizing that you are initiating shock management during your circulation. Because he's obviously showing signs of shock, and you check a pulse in that time frame too. So make sure you get your pulse during the primary. You did good catching the sucking chest wound. He has JVD, so make sure we're monitoring to burp that dressing, see if that fixes anything. Obviously, there's not much that you're going to do for decreased lung sounds. He probably has a pneumo or a hemo at that point. So just keep an eye on those vitals. Make sure you're palpating the chest. You want to feel for any rib fractures. You don't know if you got kicked when he was on the ground. Good on that. Palpate the cervical spine. So make sure we're feeling for that step off. Check MSPs. So at least check pulses. You know, you don't have any signs of trauma, or you do have signs of trauma. Make sure you still have pulses in those extremities. You did good. You check the back. And yeah, so say, and this is just to throw it out there, say you were 25-30 minutes from a level 1 trauma center and you had a helicopter with a 5-minute ETA. You think it would be reasonable to consider flying this guy?
Yeah, with him being unresponsive and having multiple stab wounds, I mean, you never know. So that would probably absolutely be one that I would get a helicopter for.
So when you go to say, like at the beginning, you know, do I need any additional help? You can always say like, hey, based on what I know so far on the dispatch, I'm just going to like check on air medical, see if they're available and put them on standby at this point. And you can always say like, hey, I don't need them. It's better to, in the grand scheme of things in the real world, not necessarily just an assessment world, but in the real world, if you have something that you think might be a good candidate for air medical, if you're way out in the middle of BF nowhere, flight crews prefer that you put them on medical standby and then cancel them rather than call them when you're up shit creek and you just dropped your paddles and now you need them because they have to do like a whole pre-flight check. So if you're going to something and it sounds kind of sketchy and you know you're far away from an appropriate facility, hey, can you check on status of air medical, put them on standby, go from there. Just keep that in mind with your
that like air medicals and thing, just because where I work, like the hospital's literally at most 8 minutes away and they have the, yeah. So it's like, if we call in our report, they immediately decide if they're going to get flown or not. So I always forget that that's a thing.
just keep it in the back of your mind as an option, just with assessments and stuff. But otherwise, good job.
Thanks. Do one of you want to go next?
Okay. I think Ed's already got it there. Well, did you do your trauma? Yeah. Oh.
Hi,
Hi.
Mandy Henderson.
Yep.
So this is my.
I just never actually see you, so I feel like I have to tell you who I am.
I've done process of elimination so far. I think this is like the least interaction I've ever had with a class that we've taught. Like, I think I've taught you guys like twice.
Mm-hmm.
Are we doing trauma or medical?
Medical.
Medical.
Ready whenever you are.
All right, let me finish filling this out real quick. And let me find you a scenario. All right. So your time is 2028 and you are dispatched for a 19-year-old female complaining of abdominal pain.
All right, BSI, my PPE is on. Can you describe the scene as I'm walking up to it?
The scene is safe. It is an apartment complex. Patient's on the 2nd floor. There's no elevator.
All right, where's the patient at as I'm walking into the room?
She's sitting in the middle of the living room on the ground.
Okay, is she bent over or just kind of sitting normal?
Just crisscross applesauce.
Okay, so this is an illness. We know that from our, okay, we're assuming that from our dispatch. We'll take that with a grain of salt. It appears that we have one patient. We're gonna consider C-sign, but right now, since it's sounding like an illness, we're not gonna have to worry about that right now.
Okay.
We are gonna see if you just keep it in the back of our head, any ALS providers additional if we need any help. But right now, we're gonna see what we have.
Okay.
So right now, my general impression is going to be a 19-year-old with abdominal pain, sitting on the floor, not in terrible severe pain since she is sitting normal. So we're going to continue on. What was that?
Oh, I'm sorry.
Oh no, that's okay. I thought that was a car squealing outside. Sorry. Level of consciousness. Does she respond when I talk to her?
Yep, she's alert and oriented ×4.
Okay. Okay. What is her chief complaint when I'm like, hey, what's going on? Can you explain to me what happened today?
She says, my stomach really hurts. It's sharp. It's low, a little bit to the left side.
Okay. She's talking to me. I can see that her airway is open and patent. She does appear to be breathing good. I am going to look while she's talking to me, watch her breathing, look for any rales, any increased labor of breathing. I am going to pull out my stethoscope, listen to her lung sounds, look for any abnormal sounds like crackles, rales, absent breath sounds, wheezing. Do I hear any of that?
No, lungs are clear equal bilaterally.
I am going to assess her circulation. I am going to look for any obvious signs of bleeding. Do I see any of that?
No signs of bleeding.
Okay. I'm going to check her skin color and her temperature and whether her skin is dry. I'm going to do that while I check her pulse. Can you describe her skin color, refill time, and pulse for me?
Skin is pink, warm, and dry. She's got good cap refill. Heart rate is sitting at about 86 regular.
Okay. So we're gonna stay and play for a minute. We have time to obtain our other history. So I'm gonna ask her, what was she doing when this started?
She says that she woke up from a nap and she just noted she had really bad abdominal pain. She's been nauseous all day with intermittent vomiting.
And does anything make it better?
No.
Does anything make it worse?
No.
Okay. To rate your pain on a scale of 1 to 10, 1 being none, 10 being the worst pain in your life, how would she rate that on her?
She says it's about an 8.
About an 8? Okay. Is the pain just in her belly or does she seem to have pain anywhere else?
She says it's in her belly. It's kind of towards the left side, maybe a little bit in her back, but nowhere else.
So it radiates to the back a little bit.
Yep.
The quality and severity, can she describe her pain? Like, how does it feel to her?
She says it feels kind of crampy, like somebody kind of has their fist in her stomach.
Okay. And then when did it start?
She says it started about 2 hours ago.
And then signs and symptoms. So do I notice anything besides her appearing that she may have abdominal pain?
Nope.
Okay, so she already said that she's nauseous as well. Does she have any other symptoms?
No, just the abdominal pain and nausea.
Is she allergic to anything?
No.
Is she on any medications?
She takes daily birth control.
And what kind of medical history does she have?
She has a history of PCOS, polycystic ovarian syndrome. She is G1, P0, A1. She had a miscarriage when she was, or an abortion, excuse me, when she was 15.
Okay. When was the last time she ate?
About 6 hours ago.
And she had no pain after she ate, correct?
Nope, no pain.
Okay. And the events leading up to this, we already talked about. She said she went to sleep, didn't have any pain, woke up, now she has abdominal pain.
Yep.
And you said that it was the right lower, is that correct?
Left lower.
Excuse me. All right. So I'm gonna start talking to her, be like, so do you have any headache? Any dizziness?
She says occasional dizziness, especially when the pain's really bad. It kind of just takes it out of her. No headache at this time.
Okay. Do her eyes appear to be active in, oh my gosh, equal and reactive while I'm talking to her?
Yes.
She doesn't have any facial drooping, anything like that, correct?
What'd you say?
No facial drooping, slurred speech, her speech is normal. All right, well, I'm looking at her, neck veins flat, trachea midline.
Yep.
All right. I did listen to her lungs. They were clear. I'm gonna go ahead and listen again just to make sure nothing's changed. Are they still clear?
They are.
All right, I'm gonna observe her breathing. I'm gonna ask her, does she have any chest pain?
No chest pain.
No shortness of breath?
Nope.
Okay. Does she have any burning in the middle of her chest along with that nausea?
Nope.
Okay. And then her abdomen. I'm going to palpate her abdomen, leaving the left quadrant for last. I'm going to push with even pressure with both of my hands. We'll start at the right upper. We'll do the left upper, right lower, and then left lower. Does she complain of any pain when I push on them or when I let up?
No, she only complains of pain with pressure in that left lower quadrant.
All right. When was their last menstrual cycle?
She says she doesn't know exactly, but it was last month sometime.
Okay. Is there any chance she could be pregnant that she knows of?
She is sexually active, but she doesn't think so.
Okay. Any pain on urination?
No.
Any diarrhea or constipation?
Nope.
Okay. Does she appear to be moving her legs and arms normally?
Yep.
Okay. All right. So we're gonna go ahead. We're gonna get her out to the truck. We'll probably use a stair chair, just that she gets dizzy sometimes when moving. We're gonna get her loaded to the cot. There, I'm going to get our baseline vitals. What is her blood sugar?
Blood sugar is 98.
98. And what is her heart rate?
Heart rate is 86.
86. And what are her respiratory?
16.
16. All right. We're not going to do CAPNA right now since we're not complaining of shortness of breath and all of our vitals appear to be stable right now. What is her blood pressure?
Blood pressure is 142/86.
And what is her temperature?
Temp is 98.7.
98.7. All right. Does she have any vaginal bleeding at this time? Or
She says no.
okay. All right. So we are going to hook her up to a 4 lead. Does that have any abnormalities in it?
Sorry, say that one more time. The radio's pain in the butt.
Oh, no. That's okay. I'm going to hook her up to a 4 lead. Does she have any abnormalities?
Nope, just normal sinus rhythm.
Okay. We are going to start an IV, preferably AC or forearm, just to have IV access if we need it. We'll just probably lock that. I will give her Zofran 4 milligrams ODT to see if that does help her nausea.
Okay. She says it helps a little bit.
Okay. After I give that, we're going to start transporting after I get those vitals. So an IV. So we'll be transporting. I'll give that Zofran. I am going to do a secondary assessment on her. Are all her vitals about the same?
Yeah, everything's about the same.
Okay. We are going to take a nice easy trip to the hospital. I'm concerned about either a PCOS flare-up, some type of cyst, could be potentially even some type of diverticulitis or ectopic pregnancy. So
Okay.
we're going to monitor her for any signs of shock or any type of bleeding that we could have en route. We're going to monitor her that pain. If her pain is worse, depending on protocols, we may give pain medication as, per protocols. Otherwise, we're just going to monitor her en route, rechecking her vitals every 10 to 15 minutes. Yeah, I think that's about it.
Anything else?
No, I think I'm good.
Perfect.
Yes.
Good job. 9 minutes. You did everything. The only thing I can think is that when you do your airway and breathing assessment in your primary, if you're not going to put them on oxygen, just say you're not going to put them on oxygen. Say like, hey, at this time, I don't think oxygen therapy is necessary. I think she's doing okay herself. Yeah, I think you got everything else.
Okay.
She, no,
Good deal.
She was my patient. That's a real patient. She was my patient about 2 weeks ago. Absolute sweetheart. She was 19, has a history of ovarian cysts on her left ovary. She said she thinks one's popped.
That sucks.
She's an absolute sweetheart. She got Zofran and fluids. That's all we did.
Good deal. Good deal.
Good job.
Was I your last person or do you need somebody else?
I don't know. That's up to you guys.
Okay, let me ask around and we'll let you know.
Okay.
Yeah, and some people wanna try it.
Oh, fuck.
Hi.
Howdy.
Are we doing a medical or a trauma?
Trauma, because I already did that.
Trauma?
Yep.
Give me 1 second. Take a minute to write down whatever you need to write down. Let me pick a scenario. All right. So it is 2041. And you are dispatched to a job site emergent for a 36-year-old male fall from scaffolding.
All right, first thing on, I got my BSI on, my CNSAFE.
BSI is on. Would you ask? Sorry, I can't. Scene safe. Yep.
All right, what's my mechanism of injury?
Fall from scaffolding.
All right, so then for C-spine, I would probably take C-spine precautions, put a collar on him.
Okay.
I would possibly request additional help. I don't know yet.
Okay.
All right. I guess what's my general impression?
You have a 36-year-old male laying on concrete at a construction site next to approximately 15 feet of scaffolding.
All right, what's his like level of responsiveness?
He is alert and oriented ×4 with a GCS of 15.
All right, so is his airway pain?
It is.
Airway's pain. All right, how's his breathing? Like rate and depth?
He's breathing 30 times a minute, shallow. It states it hurts to take a deep breath.
All right, go to circulation. Does he have? Obviously, he has pulse. Is there like any major bleeding that I can see yet?
No, not yet.
All right.
Give me 1 second. Let me turn this radio down. What's a police radio? I don't know why we're scanning police. We don't think it's not even our police department. Okay, anyway, continue.
So then like for transport decision, I'd probably say emergent just because of his breathing. That's kind of a problem. You say he was alert oriented. All right, so probably gonna begin my trauma assessment. So kind of just look at his head, look for any bruises, contusions, anything like that?
He has nothing remarkable on his head, but he does admit to a loss of consciousness after the fall.
And what does his pupils look like?
Sorry, I can't hear you. It's the computers.
You get like his pupils are equal and reactive.
Pupils are, let me see. Yeah, pupils are equal reactive.
All right, I'm gonna move down to like the neck area. Any like injuries or anything abnormal there? Any like jugular vein distension, anything like that?
No JVD at this point. Trachea is midline.
All right, and while I'm there, I'm gonna palpate his C-spine.
No signs of step off.
All right, cool. I'm gonna inspect the chest, take off his shirt. Is there anything abnormal there?
Yeah, you note paradoxical movement on the left side.
All right, then what is the lung sounds like?
Lungs are diminished on the left side.
Diminished, okay. So, yes, inspect like the abdomen, look for anything rigid.
Okay.
Kind of hardened.
Abdomen soft, non-tender.
Okay, I guess I'll do like the old like genital sweep, look at his lower extremities, look for anything wrong there.
Legs are good.
Forms or anything. Okay, check his upper extremities, look for like MSPs, any kind of deformities or anything.
He's got some superficial abrasions on his left elbow. Nice going. It looks like he might have a right wrist fracture. Is Joel
All right,
here? Or is
well.
this- Okay, he never came into click in. Sorry, say it one more time.
I just said I'll mark that, to treat later and just keep going on.
Okay.
So now I probably his diminished breath sounds on the left. And he says breathing 30 times a minute. But he doesn't have JVD and his trachea is midline. What's his heart rate? I'll get a baseline set of vitals, actually.
Okay, heart rate's 120, rapid and weak.
All right, and what's his blood pressure?
100 over pelt.
100 over pound. All right, cool. And he says the respirations were 30. What's his pulse ox?
90%.
90%. All right. For now, I'll probably just throw on like some supplemental oxygen, like a nasal cannula, like 2 liters. See if that gives him any kind of improvement. Actually, due to you say he has respirations of 30,
Mhm.
and I'd probably consider playing for him with a BVM.
So let's pause real quick. Paradoxical movement is a sign of what?
Would be like a flail chest, right?
Yeah. So how do we treat a flail chest?
Um,
There's the old standard and then there's the new standard.
Well, I know the old way was just kind of like put a bunch of weight and stuff on it. Thought the new standard is like positive pressure ventilation.
It is. So you have a conscious, alert, and oriented male patient who's able to follow commands. What would we use for positive pressure ventilation?
CPAP.
CPAP. Yep. You gonna put him on CPAP?
Yep, and with that, I guess I'll get a CAPNO reading, because why not?
CAPNO is. We'll just say CAPNO's 50.
That's a little bit high, so do not put too much CO2. All right, obviously it's gonna be high transport priority. Besides that, I guess en route, address like his wrist fracture, his minor injuries.
Okay.
And from there, I think that's pretty much all I would do for him. Maybe I guess if you're going with Ohio standards, you can start a line and probably give him pain meds since he's in pain. Being that his blood pressure is also 100 over palp. I guess you could give him fluids, even though I guess you want to target that 90 systolic. So I don't know if you would give fluids to increase the diastolic.
Fluids wouldn't hurt.
All right. And for the heck of it, you could get 12 lead and submit it just because why not?
Okay,
That's about it.
all right. So you're within the time limit, which is good. However, a flail segment is an injury that compromises breathing, right?
I should address that right when I heard that.
That needs to be addressed immediately. If he's unresponsive, that's when we start bagging. If he's responsive, that's when we try to start with CPAP and see what he can tolerate. So make sure we're doing that in the primary assessment. Yeah, it's Ohio standards to do certain things. However, if I have a trauma patient, do you think Sainey's Maine, UPMC, Cleveland Clinic, UH, anything is going to be happy if I walk in with a guy who fell 15 feet from scaffolding and has a breathing injury and you didn't put him on the monitor, start an IV?
Probably.
Yaz is not going to be thrilled with that at Maine. So make sure we're starting an IV, 18 gauge or bigger, something that they can use for a CT, for blood work, whatnot. Pain management is an option. But the big thing about that is we need to treat that flail segment because like immediately. Other than that, C-collar is good. However, with a fall from 15 feet with a potentially life-threatening injury, do we want to consider full spinal precautions?
Yeah.
Yeah, so I would say C-spine, somebody hold C-spine, let's do a trauma assessment, let's log roll him, check his back, because even, because in this scenario, basically the patient was walking on scaffolding and he lost his balance. He fell 15 feet and landed chest first on a pipe that was laying on the ground. So this is not a real call, I just made this up. And you still want to check that back. If he falls chest first, when we fall on something, we're going to fold, right? So he might have hit his chest, but then the rest of him folded like a book. So we want to make sure that we don't have any trauma to the back, any hyperextension or anything like that, any pain back there. We probably want to throw him on a backboard and maybe look at some pain management. Be leery of pain management, I would say, because his pressure's a little low. So it wouldn't hurt to give, I know we're titrating to 90. However, it doesn't hurt to give just a little bit, just a slow rate KVO isn't going to kill him. It's not going to make anything worse, but you're on the right track. Just study that skill sheet, get that flow down. It doesn't hurt. You're not admitting defeat if you take a piece of paper in and write out everything you need to remember. That way you don't forget anything. Not terrible.
Okay.
All right, you're good.
Is there anybody else?
I don't know. You're going to have to ask around because I know Ian's doing them too. So see if there's anybody else that needs to come see me.
All right, I'll find out. Thank you.
Okay. I don't know Sarah yet. Sounds good. Hi, Mom. I'm just
Go
trying-
ahead, fail me. I dare you.
I'm sure I could come up with something that Beaver County's handed to me.
Hey, who else do you need?
I have had a medical for Angie, a medical for Jesse, a medical for Sarah, a trauma for Destiny, a medical for Destiny, a medical for Mandy, and I just did a trauma with Tyler. So I don't know who's going with what other preceptor to do what.
Ian, are you done? You guys are good. If you guys are done, you guys are good. So for you, how many did you do with Destiny?
Yes.
I did both a medical and a trauma.
You're good. She already did it with Sarah, both with Sarah. She said she didn't want to come to
If
you.
have No, I'm sorry, I lied. No, Ian, stop.
Do we have any issues or you all good? You, Sarah, okay. All right, we'll talk. Are we good for sign-offs or no? Because this was skill finals.
Let me send you a message.
Copy that.
Okay, well, we'll leave you to it.
I see it done like people, and it's like from the Dollar General.
You could also go home.
So yes, just let me know how he does. I'm curious to see. Hopefully it helps get it.
I still wanted to talk to you about a couple
So I
things.
think
and
helping get that.
couple
under
of
control.
stuff.
Yeah.
I wondered about, yeah.
So Saturday, so Chris said that
You have
initially the
plastic
plan was to
utensils
take
around
the
here?
test and then in the afternoon we would finish all of our skills. So now that the skills are done, are we just done after the test?
And the only other thing that's gonna change that is that when I go through one more time and make sure, excuse me, that there's something that you guys need for clinical sign.
But you would let us
Yes.
know.
I'll let
Are we
you guys
gonna
know.
be here? On Saturday? Over there on Saturday. So
Bye.
I have ER scheduled after.
All right,
see you later.
See ya,
After class on Saturday, sorry. So, and I just need to think, maybe
Okay.
just turn that in and everything will be good until registry.
Oh, my trauma assessment.
You need a trauma assessment? Can you do her when you're done eating? Go do her trauma assessment. Let him eat. Let Ian eat. Go do her trauma assessment. in front of him.
No, I'm the patient. You just hit me.
What just happened?
Saline, so I sprayed it with the Dawn Power Wash.
I wasn't even there anymore.
Oh. The big day.
Hmm.
Did you see him already too?
Yep.
Okay.
Dynamite penne would be big up.
I thought you mega ball.
Let's say there's 24.
Okay, did you review that with him, Sarah?
Yeah, we went over it. I kind of stopped him in the middle of his assessment.
Okay.
I'm just filling out, I didn't have a skill sheet when Angie went through hers, so I just have a couple notes that I'll throw on her page, but she was on the right track. She did good.
Yeah, because I have everything else. I went through and approved everything and made them see what was missing for their opportunities and stuff like that. And I told them, I said, as long as you guys have the stuff I can't make up for you, like the in-person stuff. Other than that, from what Chris told me, everything else has pretty much been done. It's just a matter of if we don't have the documentation, we need to create the documentation because they did it. It just might not have gotten added because of the technology issues.
Yeah, I'll scan everything I did and email them to you. That way you can put them wherever they need to go.
Actually, if you can just, I think Ian created a lab for today, so you can log in as a student and just upload it.
Okay,
Just so you'll still have to grade their lab, like how you've been doing the other one, and then just add that to it.
I'll just have to see. I'll look at that. I'll look at that when I'm done with this and I'll text Ian if I need help.
That actually worked out great though, because I had John did IV med and got them done on that. And then you and Ian were doing assessments, and then I had them in the front office reviewing individually what they still needed to do to finish up class. So it worked out and we're ahead of schedule. So, and that was with us starting late too. So I was talking to him. And then I did the same thing with the EMT class. Oh my God. Well, yesterday I was like, okay, so I walked in, they're like, we thought the exam was today. And I'm like, and that's not what Chris and Sarah said. If you guys want to take your final, you can, I'll schedule it. And they're like, well, that's what we were understanding. And I'm like, that's not what those two told me that they told you.
I I realized like last minute that I had like 2 texts from 2 different students and I didn't get home from work until probably 8 a.m. because I had a patient fall while I was walking them to the stretcher. And because I have anxiety, I wrote the incident report, then sat in the office until 6 when Bill came in to just deal with it. And so after that, I was like polishing up the truck because Dixie follows me on night turn and I had worked with Kat. So of course it didn't get done.
Right.
And so I think I had a text from Tabitha and I just didn't get back to her and I felt really bad.
About what? What was it?
I think
From
it was
yesterday?
about class, like if class was like in person or something.
Oh, we ended up putting it on their thing anyway. So yeah, she was there. They're pretty much done. I think I sent you what they need to do for,
Oh no, it was Aiden who had texted me.
he's the only one that.
And then also Ian apparently texted me and I ignored him, so. Sorry.
Yeah, Aiden needs 2 patients and then Bob and Tabitha just need 1. And they're
Not
done.
bad.
No.
I'm gonna post on the A's classroom, just a couple of notes that I took from tonight about like things that I think they could work on. Cause it was. We need to be stating field impressions and it's not like critical fail stuff. It's just those points that if you keep missing them, they're gonna get you. So field impression, we need to be repeating primaries and secondaries, questions related, if the patient complains of dizziness in the secondary assessment and then you're giving them fluids, it might not be their chief complaint, but we need to be like, oh, is their dizziness getting any better? Like that's an established symptom. I don't know why everybody's like, oh, I'm just going to start an IV, but I'm not going to put them on the monitor. Like if you're starting an IV, there's no reason why the patient shouldn't be on the monitor, especially because you're going to be giving meds. Get a 12 lead and send it. It's not going to kill it.
I think that's what's holding them up because I had that discussion with them too when I did one of theirs and I had said, why aren't we? And I
Is
think
it in the A scope to monitor a 4 lead? No, you have to get that 12 lead and send it. Okay. So it doesn't hurt. You're starting the IV and giving the med, have your partner throw on a 12 lead and get a 12 lead. You have a patient that is having an allergic reaction that you gave epi to. A 12 lead's not going to kill it, and then
it smells really good.
Yeah, well, I'm learning on the hard way. The reason why it's called dynamite and why it pays to read the label, it says spice, it says maybe tomato sauce. Okay?
Oh, we don't do spice?
Got a little bit of spice.
Oh, a little bit too much.
Ian downed an entire burrito at Los Galos or whatever, no, El Paso the other day, and then spent like a solid 40 minutes in the bathroom at Calcutta.
She's like, did you at least spray like a scent or whatever? I was like, I did, and the automatic one sprayed a couple times while I was in there.
I was like, did you leave the fan on, please, dear God?
However, he introduced my kids last night to
The pickle
the
fries.
pickle
at Sheetz.
fries. Yeah.
Ooh.
Because they weren't bad. I'm not a big fried pickle person, but I would eat them. I just have them myself. But the girls love, well, especially Amelia, or Gwendolyn, I mean. So you're coming Saturday? To the
So the
party?
thing, yeah, sorry, I put in a vacation day and I got it. I have my cousin-in-law's bridal shower in the morning that I'll be at until like 1. So I'm done by the time that thing starts.
I'm just forewarning you, there is a little person who is already planning on talking to you.
Yeah, I figured.
Because she asked if you were coming and I'm like, yeah, and she's like, we're gonna have a talk.
If it makes her feel any better, I have not taken the top off of the Jeep for myself.
She's not gonna care.
Like I have not done it at all this summer. I've meant to a couple times, but then I like look at the car and I'm like, wow, that's such a mess. I would have to take everything out of it and it would just take too much time.
Oh, what are you doing Saturday? Saturday night, like at 5.
Don't really have any going on.
You wanna come to the events thing? We're having what do you call that? An engagement party.
Oh, okay.
It's across the street,
Yeah. Okay.
but it's good food. It's Buck's cooking and it's gonna be.
Yeah.
Ooh, Ian, you have to go.
Oh, yeah. Well, you have to go.
Oh,
We
yeah.
need to have Ian come to the gun bash.
Yes.
It's a fun time. It's in September.
We also have tickets for sale, $10 a piece to get in a drawing of a kind of like a bar table built, made out of a fire hydrant made by Captain John Walsh with bar tools.
Yeah, bring it down.
John Walsh has so much time on his hands.
So,
All I have is the Safety Forces Appreciation Day or whatever, till like 2:00 in Poland on Saturday.
I feel like from like 5 to 9 or something like that, but
I mean, Chris might be upset that I don't help for the class, but I show up at the party.
there's nothing to do for the class. It's just gonna be their final, that's it.
Oh, he asked if I was available for Saturday. I was like, oh.
They don't need to be doing anything on Saturday. At this point in time, there's nothing to do. What are you drawing?
I don't know.
Yeah, okay.
Doodling.
So,
Who's your partner up there in Springfield tonight?
Joel.
Okay.
I had Austin until 8.
You'll have me, Sean, and Jordan Little as at mutual aid tonight because I'm on duty in Poland midnight to 8.
Okay. They just got a call. I forget what for.
Yeah, I saw the alert come through.
so we have, you good there?
Yeah, I was trying to make a loud fart, but it was quiet.
Yeah, well, those deadly ones.
Yeah.
So we have. Let's see. Destiny needs only like, I don't know, maybe 6 more IVs and she's done. And then,
Hopefully it's still recording.
yeah, well, it's fine. We're not on YouTube anymore. Or
So
does
what?
you? I can tell.
Students left.